I was very impressed so far by the content of this session. I also appreciate a lot of interaction between members of the heart team. I think it should be like this because we are ultimately treating the same patients, and we should have like consensus between the members of the team and different, let's say, group in the hospital. Only missing component maybe of the heart team this morning were patients because I felt that they are part of the heart team, and potentially administrator also from your talk, Eric, because you should probably invite them to a meeting like this. I think we saw a nice live case from Montreal Heart this morning. Was very smooth, very beautiful end result. Beautiful also tape case by Dr. Bouchard showing a mini invasive approach and a sutureless valve. Also following the Nicolo Piazza talk, I think we realized the importance of imaging in the TAVI. I think there's no doubt imaging, it's part of the learning, it's part of this procedure. I was also impressed by the quality of the talks of Eric and Marc. I think you gave a nice overview of what we know in different fields. So at this point, Don, you want to say something more? Yeah, it's lunchtime. No, don't be too long. Yeah, we are right on time,
they told
right?
me I got 15 minutes to kill. You know?
No.
I too appreciated very much the talks. Marc, I think you always present such a balanced, appropriate approach to both sides. My question's for Eric. Eric, I like also the way you sort of described what a team is, right? Not everybody does the same thing in a team. You have defenders, you have scorers, you have a goaltender. I mean, you don't expect a goaltender to score, etc. Now, I'm going to try to push you a little bit more on that. What do you mean by that?
Okay. So let's put it in very simple terms, okay? So we're a heart team. Our heart team makes decisions about surgery or a transcatheter procedure, right? Do you think it would be sensible for me to do the sternotomy on the patient we've discussed who's going to surgery? Probably not. Nope. Do you think it's good for me to do the distal anastomosis on the bypasses? Not a good idea. Should I close, put in the chest tube? No. Should I be the first assistant? No. Shouldn't be the first assistant. So I think, and listen, I volunteer, and you know, when we have these discussions with my own heart team, they're difficult discussions. We want to put ourselves in a position where we're going to win. And when we win, it means our outcomes are good, our quality is good, our standards are high. And what that means is if you have two guys in your institution who do full-time intervention and do high-end structural cases, that those are the hands on the catheters. This is not playtime, and it's not learning time, and it's not high school, and it's not everyone gets to do everyone, and we're a big happy family. It means that we're going to leverage our expertise to get the best outcome for our patients. And that means when it's your dad or it's my dad, that they're going to get the best care. And that's the model. And if you can't live with that model, then it's a problem. That's where there has to be leadership.
Okay, so, and I like that. Now so you have a highly skilled surgeon, highly skilled. I mean, to me, this is like the Rangers. You know what I mean? These guys are ready to go in the worst situations possible, and they're trained to do it. But he stands in the room and watches you do stuff, and he says, hey, this is a waste of my time. Come on, I want to do something to help.
Well, I mean,
yeah. You know what I mean? That's an issue.
So Don, I guess, you know, it's very interesting because we have 3 surgeons in our program. One is very young, one is very senior, and one is kind of more senior than junior, right? Senior surgeon, when he's covering the TAVI day, he doesn't scrub. He comes from when the valve's being put in. And guys, what do you think? Are you guys happy? He's in the room. That's his role that day. Junior surgeon wants to be very involved, very hands-on. She's an aortic surgeon. You know what I mean? Like, we're working through those things. But I mean, like, you know, people's feelings and their desires and what they want, at the end of the month, you got to be able to pay the bills. And I don't mean financially. I mean, like, you got to have the ammunition in your arsenal to take care of the patients. And, you know, I think that's what's important in the end. Like, you just can't get around that central principle that the best person or the best people who are suited to do a task should be doing the task.
So Eric, this is Nico here.
Yep.
You know, Don asked you, so what do you mean? So what you're saying is that you'd expect Marc to say, do you expect me to put in percloses? Do you expect me to cross a valve? Do you expect me to perform the balloon valvuloplasty as a surgeon? And he should answer, no, I shouldn't be doing that. I think that's a little bit, you know, what we do in the cath lab is a skill, and a skill could be learned. You know, I worked 2 years with surgeons in Munich, and they performed transfemoral TAVI since 2007, and in fact, they were the most prolific center in Europe doing TAVIs, and they were getting results just as good as the interventional cardiologists. So, you know, it's, of course, everyone has a role, but roles can be learned. And, you know, we have Marc up on the podium, and I would like to hear what he has to think about all this.
I'd like to just respond to your question. I think you're 100% right. Just because you were trained as an interventional cardiologist doesn't mean you're the best TAVI doctor, right? It's like these skills can be learned, but there's got to be more than 2 days a month, right? That means that you have a dedication to a skill and a technology. I mean, because I trained as an interventional cardiologist doesn't mean I can't cut down on a groin or I can't learn how to do that. But I'm going to have to spend the time to know everything about that and to put in the time. It doesn't just come as a natural progression of surgery doing an intervention. I 100% agree with that concept. It has nothing to do with title, has everything to do with training, experience, and practice.
Exactly, yeah.
Yeah, so Don, I think thanks for asking that question, because I think it is the elephant in the room in a lot of programs. And I've gone to Proctor at places, and you see a really wide variety. You see in some centers where it's very surgeon-led, other centers where it's, as Eric is describing with his senior colleague, where the surgeon walks in the room and the arms are crossed and there's very little involvement. And I think that's a detrimental approach to both of our professions, frankly. Now, having said that, I also agree with what Eric says, that the onus is on us as the surgeons to be properly trained and not to go into that procedure expecting that we're going to be doing everything from start to finish and not having some of that experience. Now, having said that, there's some translation from PCI to TAVI, but let's be fair, TAVI is not that complicated. It is not that difficult of a procedure for most patients. And there's a skill set that I was fortunate to learn on the job with cardiology colleagues that were willing to be patient with me, whether it was crossing the valve, understanding the balloon. And I already had some of those skill sets from my EVAR experience at Stanford and from thoracic stent grafting. But for us, I think the bigger issue is as a profession. And you can imagine the angst among your younger colleague, which is the graph that I showed, where right now we're only looking at 10 or 15% of aortic valve replacements. And there's a self-preservation issue for young surgeons that they want to be involved in this. And if they're not, they're going to look at a substantial proportion of their practice going away. But the onus is on us as training centers to train these people properly. And I don't think training properly means that within a 6-year integrated program that they come out of that with full wire skills to be able to be a fully functional TAVI. But just like we send people a year to do transplant or VADS, or we send them a year to do complex aortic work, we probably need to send them away to do a true structural heart fellowship, and that they can come back at your center. And then the challenges at your center is how do you integrate that with your cardiology colleagues. And certainly what we did is we really tried to make it that it was a quid pro quo, that in the morning at the New Brunswick Heart Center, Vern Paddock would do the case and I'd be second, and in the afternoon I would do the case and be deploying the valve and he'd be second. He would take care of the patients when they would come into the hospital for their pre-assessments. I would take care of them after all their procedures. So, for us as surgeons to expect that our cardiology colleagues are going to do all the pre-op and all the post-op and all that, and then we're going to go in and implant the valve, I think is unfair. But I think if the surgical and the cardiology teams are able to have those discussions and work it out ahead of time, I do think you end up with a much stronger team. People have their role, but I think both people need to be involved.
Great.
Yeah, more of a comment rather than a question. François Désy, I'm with the INES, Institut National d'Excellence en Santé Services Sociaux.
Good, welcome.
So the HTA. Well, I didn't expect that. No, I just wanted to mention that within the current, at the end of the month, basically, we're going to be providing the Ministry of Health with a list of quality standards related to the TAVI practice, and it's going to be based on a couple of, we call it énoncés, that we're going to submit to the committee of expert committee. Dr. Ibrahim is one of the members, Dr. Dano, and hopefully we're going to be helping, I guess, promoting the true collaborative approach of a heart team and create a consensus around what the TAVI standards, quality standards or practice really should be like in the Quebec environment, and eventually get to reach the better or the best patient outcome possible. So just want to mention that, and I'll be probably meeting some of the members that I don't know during the course of the next day.
And don't forget budget.
Yeah, we make recommendation. We don't actually make the decision, but definitely it's going to be something that we're going to be looking at. Thanks.
All right, any more comments? I think it was